Hi everyone. We're going to come back and do part two of our lecture, which is cryoneuralysis for the lower extremity. So glad you can join us, and we're going to continue on like we did for the upper. As I stated, all of our information is in our textbook by 30 authors around the world. So we're going to start, and much like I've discussed in other parts of the body, it's very important to understand the fascicular arrangement. So there are branches of the femoral nerve to both parts of the rectus femoris on either side of the tendon, which is that comma. You can see the rectus femoris is more of a thin muscle at the top if you look at this diagram. So we're going to be targeting branches on both the medial and lateral aspect of the rectus femoris. If we look at closer, there are fascial planes which can get quite thickened as well, and sometimes we even scrape them away when you feel that inherent stiffness bending the knee even after you treat it. So everyone's anatomy here is a little bit different. This patient has quite a large sartorius muscle, and with the sartorius, it will be over the rectus femoris, and other patients will be a bit over, but it's very easy to see the rectus femoris besides the femoral artery with that classic comma. And we're going to put our needle right in it. So if we look through our teaching video, we are going to start with immediately you see the blood vessel moving away, and in the middle of the screen you'll see the rectus femoris, that little tendon coming down the middle, and we're going to target branches on either side. So that is the main way for the rectus femoris, but then underneath it is the vastus intermedius. And if the rectus doesn't make it flexible enough, then we add in a nerve block to the vastus intermedius, and then we go laterally to the vastus lateralis. So depending on the gait pattern, sometimes we do all three muscles, particularly someone who's very stiff with, say, multiple sclerosis. So going through again, you're going to start at the artery, you're going to move closer towards the rectus femoris, get two branches, and then go deeper into the vastus intermedius below. They're very easy to stimulate and get the result that you want. And then move out further to the lateralis. So if we look at this video, we can get a image. It will play. And here you can see we are stimulating the medial part closer to the vessel, and you get a nice fascicular stimulation with lidocaine. Then you're going to have to move out and do the other fascicular. So if we see it here again, that's what it looks like. When we do cryoneuralysis, we are stimulating, and again, we're getting a very, very nice stimulation. This is a bit fibrotic, this rectus femoris, and you see immediate fasciculations happening. So you can see which part of that muscle you are stimulating. Here's another view. So now we are going to go sliding onto the adductor region. So we are now going to the adductors, going to the other side of the femoral nerve. So what we note, the femoral vessels are on the lateral aspect of the vessel. The anterior division of the obturator and posterior slide medially going off. So we're going to target both the anterior and the posterior. So sliding away from the sartorius, coming medially, you can see the adductor longus, brevis, and magnus lined up this way. And we're going to target the two different individual branches of the anterior and posterior division, and it's very important to get both. Sometimes we just go intramuscularly if you can't see those divisions very well. So what it looks like in this view is you see the anterior division. If you're going in the sagittal plane, you're going to see the anterior division off that first layer of muscle, and then below the blood vessel, you're going to have the posterior division. So here would be a case of a patient that we treated in Switzerland, a CP, who has both adducted legs and flex because of hamstring tone. So we're going to have to treat the adductors and the hamstrings to get the legs apart. Very tight. So I'm just pointing out our target for the adductors. And then after the procedure, he is able to open them nicely. Now, in a patient with cerebral palsy, there might be significant problems with the hip formation. So in these cases, we're looking for less on the Ashworth scale. We might not get increased range of motion because of all the factors that affect the adductors. Going into the hamstring muscle group, it's very similar. So we're going to look at three muscle groups. You have laterally the biceps femoris, but medially you have semimembranosus and semitendinosus. So we usually go after the medial, the semimembranosus, semitendinosus, but if needed, we also do the femoris. So this is a example of those videos that we will do. So if we look at the arrangement, you have semimembranosus, which proximally is very small. Then you have semitendinosus and biceps femoris. So in this arrangement, you can see here, we can go, I will often put my needle in and get tendinosus, slide further into semimembranosus, bring my needle out, aim the other way if needed to get to the biceps femoris. And we just find that the two medial are the stronger ones, so those are usually the ones that you need to do. And we have now slid from the semitendinosus into semimembranosus, and we are getting the second branch here. And you can see the stimulation from the needle. And then we would go to the biceps femoris next if we needed to. And it's nice that you see the fasciculation, sorry, the stimulation and fasciculation breakdown. And this would be an example of what happens when we do those hamstrings. And this was just the semimembranosus and semitendinosus. We didn't need to do biceps femoris. So if we put it together, here is a nerve block sequence of a patient who has an incomplete quad. So, I call it the cascading waterfall of spasticity. You block one, it's still tight. So you can see she has stiffness in her quads, but also stiffness in her hamstrings. So it's hard to know what's what. So we begin by just doing a rectus block, and she's looser, but I still feel resistance to movement. So she can bend it, but it's still quite stiff. So now we add in vastus intermedius, and it's become much looser, but there's still hamstrings tone. So we've done 2 blocks, but there's a catch and release. Now we add in the hamstrings, 1, 2, 3. 1, 2, 3. So much looser. So we want to make sure with these blocks that she can get up and walk between blocks. Here is a more significant case of a spastic diplegic who has both quad tone and hamstring tone. And look at the change, particularly in the hamstrings. And this patient is coming up to 1 year and feeling like they're getting a little bit tighter. They are still maintained, but we'll probably repeat it around the 10-month mark because she really liked the improvements that she had. One of my MS patients that is a golf pro and really had difficulty, couldn't flex the leg circumducting, and she's learning after the procedure to walk with a flexed knee, which she finds much better than circumducting.
Lift your leg up to your waist.
This was a lovely case of a patient with multiple sclerosis who, she could not flex her knee up to her waist. Very difficult. And it actually turned out she's incredibly flexible. She did yoga for years. And after the procedure, she just kicked her leg right up to her face. And, she said, oh my God, I went up and did stairs right after doing yoga. And what was very emotional, we didn't know this, but she's getting married. And she's Iranian in background and was hoping to do traditional dancing at her wedding. And she was so scared that she just fall on the aisle walking down because she falls multiple times a day. Now she can clear her foot and walk, and she was dancing. So she's looking forward to dance at her wedding. So it's a really nice story. This was a fascinating case.
Look at the heel touching the ground.
So her heel's touching the ground after she's 80 with CP, and she got admitted to hospital with severe pain in her legs, inability to walk. And my suspicion is that she was
taking
getting
a video of you walking because it's
causing worsening of her underlying tone. But, we couldn't even transfer her to the bed. So we did her adductors and hamstrings and calves to free up her leg. So she was admitted to hospital, and hospital they thought she was going to go to care.
Your heels almost touching
we treated
the
her,
ground.
and she was discharged home doing stairs the next day. So very much looking at which are the muscles causing her spasticity, and just a really nice
extend
outcome.
Extend it.
And you can see before treatment, the hamstrings are so tight. The foot is quite plantar flexed.
Okay.
And then the other side. I'm just going to do it slowly.
So, we just cannot extend the hips
And
or
the
get the
adductors.
hamstrings extended. So huge gain in function by combining these different targets. And her adductors are tight, as you can see, and there's that spastic component.
Oh, okay. Can I do this one last one?
Yeah.
So we're explaining what we're going to do to her here. We started with the whole tibial nerve trunk at the beginning, so we always had to make sure the patient had a severe spasticity in their leg and they could tolerate the anesthesia of a tibial nerve trunk, and we've completed our study on 48 patients, mostly with tibial nerve trunks, and you just track it down from the sciatic nerve down the hamstring to get your target. More and more increasingly, because some people do get dysesthesias with the trunk, we do the branches. So very, very easy to see the medial and lateral heads of the gastrocnemius with the nerve branches inside. I swear it takes about 2 seconds for you to see. So this would be a case of an MS patient, why we did a whole tibial nerve trunk, because she had burning feet and she didn't want that sensation. So look at the difference with her nerve block, just how she can get her heel down. And, barefoot, just the difference in her gait cycle is quite dramatic. When we do cryoneuralysis to the tibial nerve trunk, we want to see that big blood vessel in the popliteal region. We're going to insert our catheter into that whole huge honeycomb vessel. And what's interesting, it is a circle, and we know at the top you can see the medial gastrocnemius going. If we go on the other side, you'd see the lateral, and we go underneath to really get the tib post and the FDL, because that seems to be the organization of that. And we've never pierced a blood vessel to our knowledge, so we haven't had that as a complication. These ones you need to do 3 to 4 cycles for a trunk because they will have intact fibers, and if they do, they will get a dysesthesia and pain. So here is a nice example of a hydrodissection of a tibial nerve. We're just going to do that, and you'll see the lidocaine flow around the nerve trunk. And here it is again, going around the top. And we're going to start cryoneuralysis in this case, and you can see the fasciculation breakdown already happening, and we're at the top, and we'll do one over the top, one down the side, and one at the bottom as well. So here would be a good example of a patient walking with their AFO, the difference in speed that they can do with the ability to bend the knee and dorsiflex the foot. So much more stable gait pattern, and is now able to walk without holding onto the wall and not furniture surfing. And this is her barefoot. So you can see, not a perfect foot, but she's able to walk barefoot, which is something that she could never do before because of the equinovarus with clawing of her toes. And here's another case. So this gentleman, which is a whole tibial nerve trunk, I'm holding him with maximum force so he does not fall down because he's highly unstable. And at 6 months after the procedure, he's able to walk independently with barefoot. And you can just see the whole quality of the gait has improved. This is how we do the individual branches. So this is a nerve stim and a hydrodissection of the lidocaine of the tibial nerve. We just go in and do medial and lateral. Just so that you know, when we're doing cryo, we don't go across the midline. We always do 2 separate because there's a lot of sensory fibers of the sural nerve going down the middle, and we don't want to get to them. This would what it looks like to do cryo. So that white area in the middle of the gastrocnemius is the nerve, and we are doing a block to that right there. This is a child that we did cryoneuralysis on. So when we want to do just motor branches, because she doesn't have her toes involved, she has good sensation, we do the gastrocnemius and then soleus, and then we often start laterally, do lateral gastrocnemius and soleus, pull back, and then do medial gastrocnemius. And on the other side, we do the same. You could also do soleus through the medial gastrocnemius, but we find through lateral is helpful. If you want to do tib post, you just go deeper from the lateral approach. So this is an example of we are in the soleus muscle, and you can see the stimulation of just the soleus under the gastrocnemius, and then the muscle will start to fasciculate and break down after we do that. So stimulation stops as the ice ball forms. Here's the lateral gastrocnemius. So you can see that fasciculation's happening as we freeze quite easily. And for the medial gastrocnemius as well. So you can see the medial gastrocnemius. We're in there quite nicely. You see the cryoprobe and the fasciculation starting. Another view of the lateral gastrocnemius, because we do a lot of these. Now, if we want to do tib post, I call it like Neapolitan ice cream. You have 3 flavors. You have gastrocnemius, soleus, and tib post. So there is the nerve branch intramuscular to tib post. And if we are here in tib post,